Good evening, everyone. I'm Tito Liotta, an orthopedic surgeon at Valley Ortho through Valley View Hospital. I've been here since 1996, and my practice is mostly shoulder. And so tonight we're going to talk about shoulder pain, what, why, and how to take care of it. Let's see if I can. So let's just jump right into it. There are many ways that the shoulder becomes injured. That's one way. The most common complaint that I see is pain, but it can include loss of motion, reduced function, weakness, trouble sleeping, or instability. And instability can be a feeling of looseness all the way to a frank dislocation. Who has shoulder pain? Well, kind of goes through everyone. Those younger than 40 are usually related to sports, overuse, from working overhead, trauma from falling, or as you saw in that cyclist. Those of us over 40, it's from life, degenerative changes, trauma from falling, from tripping, or from overuse. The shoulder is a very shallow ball and socket joint. It comprises the scapula and the humerus. The humerus and the scapula come together as the glenoid and humeral head. Both of them have cartilage, which is that smooth gliding surface. The clavicle comes together with the acromion, and that's what anchors the shoulder to your chest wall. In the shoulder joint and the glenoid, there's a sequence of cartilage, which is the labrum, a joint capsule, which is the bag, so to speak, that holds the shoulder together statically. And then there's the rotator cuff, which is a dynamic stabilizer of the shoulder. This shows pretty complex and busy slide, but shows both the superficial and busy and deep tissues that hold things together. Superficially, there's the deltoid, your latissimus on the back. In the front, there's your pectoralis muscles. Then lower, deeper is your rotator cuff. Here in back, you have the supraspinatus, the infraspinatus, and teres minor. In the front of the rotator cuff, you have the subscapularis in front. And those are the four major muscles that hold the shoulder together, and that's the dynamic stabilizers. Under that is the capsule, which comprise the labrum and the ligaments that go from the cup or the glenoid to the humeral head. When you come to me with a complaint of whether it's pain or instability or trouble sleeping, the first thing we do is listen. And I take a very detailed history. Your first visit in my office is somewhere between 30 and 45 minutes. We talk a lot and we learn a lot from your history. And then comes a very detailed physical exam where the entire shoulder girdle, including your neck, your elbow, your wrist, and hand is looked at in detail, including very specific physical exams to look at the entire shoulder girdle. We'll take x-rays, and possibly, depending on what we find and how things look, we might ask for an MRI, we may look at CT scans, and rarely and occasionally we'll do an ultrasound. There are many, many conditions about the shoulder, and this 20-minute talk will not do any of these topics justice. But there's the rotator cuff, which is the most common condition. And we have anywhere inflammation, tendinitis, partial and full thickness tears. There's arthritis about the shoulder joint, both where the collarbone meets the shoulder and in the shoulder joint itself. There's instabilities, which can be cartilage tears or ligament tears. There's the biceps tendon. There's where the collarbone meets the shoulder. The shoulder can get stuck. You can have traumatic injuries, whether it's the collarbone or the shoulder blade. And then you can have other conditions in the bone, such as something called osteonecrosis, where the bone itself dies. The rotator cuff is the most commonly complained about portion of the shoulder. And this is mostly related to how complex a muscle group this is. There are the 4 muscles about the rotator cuff, which have to work in conjunction with the muscles about the shoulder blade, the muscles about the neck, the muscles outside of the shoulder blade. And there's a spectrum of injury for that rotator cuff. Begins with bursitis, or what used to be called impingement syndrome. And just like your rope, it begins to fray as life moves on and starts to fail in a partial thickness tear that can lead to a full thickness tear. And then if that full thickness tear has progressed long enough, it can lead to an arthritis related to really bad physics from that full thickness rotator cuff tear. Impingement syndrome happens because of poor physics. The rotator cuff is a primary stabilizer of the shoulder. It holds the shoulder down and in place in the joint. And as the rotator cuff begins to fail, whether it's inflamed, starts to tear, it doesn't hold things down, and the ball is allowed to move up and impinge on either the bony roof or the front portion of the shoulder, which is the coracoid. And you can get irritation of the bursa, which is a lubricating sac between the head and this bony roof. What's in between that is the rotator cuff tendon. It can become irritated. Over time, that tendon can fail. Long time ago, we thought it was the bone that created the problem with the rotator cuff. We now know that the rotator cuff fails just like that rope that pulls the bucket out of the well. You use it enough, it begins to fail. As it fails, the mechanics of the shoulder begin to become a bit wonky, and the ball starts to move around and get pulled up, begins to rub on that bony roof, which is here. Goodness, sorry for this being a bit touchy, but it begins to rub and it creates irritation, which can then further the tearing. You can have impingement or partial tearing on the underside of that rotator cuff, so it can fail from the bottom up, or it can fail from the top down. And just like that rope that pulls that bucket out of the well, it doesn't go from normal to broken, it starts to fray and then begins to fail. The treatment of this impingement syndrome, similar to partial thickness rotator cuff tears and even into full thickness tears, begins non-surgically. We try to avoid those irritating activities, which are usually overhead activities or activities away from your body. And that rest is relative rest. So if there are certain activities or certain ways those activities bother you, then we ask you to do them differently, both in posture or how heavy you're using them. Anti-inflammatory medications can work. Occasionally, cortisone injections can help. And the cornerstone of treatment is physical therapy. And physical therapy is to try to alleviate pain, correct a lot of things that have happened to adjust for the discomfort. In other words, we begin to develop bad posture. We begin to develop corrective and adaptive activities that actually cause us more problems than benefit us. And so we work on posture, we work on improving motion, we improve strength to improve how that shoulder feels. Traditional surgical treatment for impingement, in other words, decompression, which is just cleaning out inflamed tissue, smoothing off bone spurs, or taking away an arthritic joint, have been proved to not work. And physical therapy has shown in studies to be just as good as this traditional surgical treatment. Partial thickness rotator cuff tears, we think, is the next progression from impingement. And the rotator cuff tear can happen on the top of the tendon. It can happen on the bottom of the tendon, as shown on the right-hand side of this slide. And it can progress from a small undersurface or top surface to a little bit deeper to deeper still. It can also happen inside the tendon, again, similar to that rope that begins to fray. As time goes on, they will progress, and it seems, as I've gone on in my practice, that partial thickness tears are a bit more uncomfortable than full thickness tears, especially that partial thickness tear that's on top of that rotator cuff, so the bursal side or the top-sided tendon tear. Treatment options, again, similar to impingement, are rest, doing the right things for the rotator cuff, physical therapy, anti-inflammatory medications, injections can be helpful. And then in this situation, we've been using platelet-rich plasma, which is a biologic injection. Stem cells have been thought to be helpful here, but they're fairly expensive and don't have a completely proven track record that's significantly better than platelet-rich plasma or steroid injections. And then last is surgery. And surgery is for that partial thickness tear that has not been able to improve with all the conservative measures. And surgery has been shown to be of benefit. And we know that about 80% of these increase in size over 2 years, and about 45% of partial thickness tears progress on to be full thickness tears. And my theory is that that partial thickness tear that does not improve with conservative measures is the one that's going to progress. Certainly in younger people under 45, that partial thickness tear has a higher likelihood to progress than that partial thickness tear at my age group at 62. We used to use a 50% rule as when to take these tendons down. Today, if we do surgery on a partial thickness tear, we go anywhere from placing a collagen scaffold that's been engineered from cow Achilles tendon to create a biologic scaffold for the body to grow into, which is seen here on the left, all the way to taking that partially torn tendon down and repairing it as we would with a full thickness tear, to fixing these in situ, meaning just fixing them where they lie. There's many different ways to repair the tendon, and the determinant of that is how much of the tendon's torn and how significant the tear is. And that's almost a game time decision at surgery. The decision to do surgery really has a lot to do with how someone responds to conservative management, how they've responded to conservative care, their age, and their need of their shoulder. We then progress on to full thickness tears. And these can run the whole gambit. As you see on the right-hand side are descriptions of many different patterns of tears. And they can be small, which involve one of the tendons or a part of one of the tendons. They can become large, involving 2 tendons, or massive, involving 3 or more tendons. The tendon also can retract, as you can see in this massive tear. So it pulls back towards the neck. It can involve more than 2 tendons. So we have many ways to describe these. The larger the tendon tear, meaning more tendons, or the more retracted it is, the more difficult it is to repair. The more retracted it is, the more difficult it is to repair. And the more tendons torn, the less likely that we have a great result in fixing these. Treatment options for these full thickness tears really depend on the function of the shoulder before surgery, the age of the patient before surgery, and how dependent their shoulder is on the rotator cuff. But non-surgical treatments are rest, anti-inflammatories, steroid injections, or biologic injections such as platelet-rich plasma. And again, the cornerstone of all shoulder rotator cuff rehab is physical therapy. And both physical therapy and operative treatment result in significant improvement in patient outcomes for those with symptomatic small to large rotator cuff tears. If we're unsuccessful in regaining pain relief and function, we then go to surgical treatment, which is about 25% of rotator cuff tears need surgery, which is a bit counterintuitive. When a tendon is torn, one would think that it always needs to be fixed. Well, not in the shoulder. There's enough redundancy in the shoulder that if we can make that shoulder pain-free and functional without surgery, you don't need surgery. And it's been proven in many studies and in my practice over years to be very successful. If we do need to go to surgery, the majority of times we place anchors and sutures to repair that tendon back to bone where it belongs. If the tendon tear is significant enough, we end up having to do a reconstruction. Sometimes we end up having to transfer a tendon to make up for a tendon that cannot be fixed, or we will occasionally do salvage procedures such as a subacromial balloon. There's been many studies that show that non-operative treatment can be very successful. Symptomatic patients with full thickness tears do benefit with therapy. However, the larger the tear, the more muscle atrophy and fatty infiltration, the greater the progression of these tears over time. And this kind of shows multiple different ways to fix the rotator cuff. Here on the left are multiple patterns of repair. A direct repair, which is called a single row repair. So there's one row of anchors with sewing the tendon straight down. This is a double row repair, similar here and similar here. These are anchors that are in the bone that have sutures attached to them, and they repair the tendon back down to bone. This middle picture shows what's called a balloon, and this is for a tendon construct that is not repairable in a situation where it's a relatively low demand patient, in a situation where this tendon cannot be repaired. This is newly out in the United States, and it's a very simple procedure, very short procedure, very short rehab, very short recovery time, and shown in Europe over the last 15 years to be very successful in improving pain for over 2 years and improving function with simple recovery, simple rehab, and very simple surgery. Over to the left, or to the far right, is a reconstruction. This is called a superior capsule reconstruction. And this again is for a rotator cuff repair situation where the rotator cuff is not repairable, and we're reconstructing the base layer of the rotator cuff. Works very well, doesn't increase strength, but does improve pain. And success is measured in improvement in function, improvement in pain, and then last is improvement in strength. And depending on patient age, the tear size, the amount of fatty infiltration can dictate the success. Rotator cuff tear arthropathy is a situation when the rotator cuff has been torn for many years and the physics is significant enough in that shoulder where the humeral head has been pulled up, as you see in this picture, and you actually have a joint between the bony roof and the humerus. The wear is more at the top of the joint because of the physics, and you have elevation of the humeral head, articular cartilage loss, and severe functional loss. And those patients have a lot of difficulty raising their shoulder. And this arthritis, as opposed to normal wear and tear, is related to bad physics. Non-operative options are, again, rest, anti-inflammatory medications, injections, activity modifications, and surgical options are simple debridement, which rarely works, simple surgeries and tendon transfers, which sometimes can be of benefit, but the best treatment is what's called a reverse total shoulder arthroplasty, and that's doing a shoulder replacement that reverses the physics. So where there was a cup, we put a ball. Where there was the ball, we put a cup, which takes the rotator cuff out of the picture and allows for a functional shoulder. And since 2005 in this country has been a wonderful tool for this kind of shoulder problem. So we're going to try to take it to the next step and switch gears a little bit. This is a video that doesn't appear to be working, so we'll move on to regular arthritis. The shoulder, like all other joints, can wear out, and arthritis in the shoulder can happen. This is a normal shoulder joint. The shoulder joint that's worn out, just like a knee or a hip, wears from use. The joint surface cartilage, which is that shiny end of the chicken bone gliding surface cartilage, wears, and the shoulder joint becomes painful and immobile. The history of a shoulder joint is that slow onset of dull, achy pain that then becomes painful, loss of rotation. On an X-ray, we'll see loss of that joint space. We'll see, as we see here, we'll see flattening and changes of the bone and bone spurs, as you see at the bottom of the ball. MRI and CAT scan are occasionally useful for diagnosing further troubles. Normal treatment for this is rest, anti-inflammatory medications or Tylenol, injections of whether it's steroid or biologic, such as platelet-rich plasma or stem cells, again, have been shown to be of some benefit here. The use of artificial joint fluid, such as hyaluronic acid, has not been very beneficial in the shoulder. Physical therapy, in my hands and my experience, especially when it's as worn as the X-ray that we showed in the past, has not been of great long-term benefit. And in some patients, especially when the wear is not very significant, conservative measures can buy time, but most often shoulder replacement or surgery is the best tool. When things aren't too far along, an arthroscopic management program where we release the joint, where we move the biceps, where we clean out the shoulder can be of benefit and buy somewhere between 5 and 10 years of time. A partial replacement in the young patient can sometimes be of benefit, and most often a shoulder replacement where we are replacing both sides of the joint can be of great benefit. And patients' age, activity level, condition of the rotator cuff, and the degree of wear are important considerations when we're deciding upon what to do in that arthritic joint. And these are examples of shoulder replacements. This is called a stemless, where we're really trying to preserve a lot of bone. And so the bone quality needs to be excellent for this prosthesis to work. There's a plastic prosthesis on the cup. And then this is what's most common today, which is a preserved stem. So the stem sits at the top of the bone. This is a more traditional shoulder replacement. But again, unlike the reverse, this prosthesis really needs a good rotator cuff to function and for its stability. So without a good rotator cuff, this doesn't work. The reverse works very well and has excellent success. The reverse shoulder arthroplasty works great when you have arthritis related to a rotator cuff, or when you have rotator cuff tears that are not repairable and the shoulder can't move, in a condition called pseudoparalysis, where we cannot lift the shoulder at all and it's not reconstructible. Or when there's arthritis that's so severe that there's enough bone loss that we can't make up that bone with our metal and we have to bone graft, a reverse works better. Occasional fractures are treated better with this reverse prosthesis. And then when unfortunately we have to redo a shoulder replacement, a reverse gives us a lot more tools and flexibility in doing that revision replacement. The shoulder replacement shows low rates of complication and revision. There's excellent improvement in patient outcomes, both in pain and function. There's better pain, motion, and activity scores with total shoulder arthroplasty. And depending on your comorbidities, diabetes, obesity, hypertension, and smoking, shoulder replacements can give excellent results long-term. Shoulder instability is dictated by how the ball sits in the cup. And that shoulder joint is stabilized by multiple structures. Number one is how the ball sits in the cup. Number two is how this cartilage rim or the labrum, which is the suction cup that holds the ball to the cup, is functioning. From the labrum comes the ligaments, which are the static stabilizers of the joint. And then the third is the rotator cuff, which is the dynamic stabilizers of the shoulder. And the head can partially come out or it can completely come out of the socket. When it completely comes out, you can get damage to the cup or damage to the ball, and those bony damages can create difficulties in repair or reconstruction of the instability. The cornerstone of treatment is usually non-operative. Physical therapy initially can be of benefit, and that's a dynamic stability work where we teach those rotator cuff muscles to hold the shoulder in place. Bracing can occasionally be of benefit. Most often, that bracing kind of takes the shoulder and keeps it from going to that place of instability. And then in the young patient, especially after they've dislocated more than once, repair of the ligaments is necessary. Rarely do we need to reconstruct those ligaments. When there's bony destruction, and if it's a significant enough percentage of bone loss, whether on the head or the cup, we have to reconstruct that bone loss either from bone grafting or taking a portion of bone from another part in the shoulder and moving it down to the cup. If the rotator cuff is torn, then repairing the rotator cuff can be of great benefit in stabilizing that shoulder instability. These pictures show representative examples of repair. This is repairing the labrum or that cartilage rim. When the shoulder dislocates out the front, the labrum tears, and this is a repair of the labrum, which is pretty classic in snowboarding injuries, football injuries, rugby injuries. This is representative of what's called a capsular plication. So similar to when you buy a pair of pants that are too big and you take in the waist, when a shoulder joint is globally lax and it's slipping and sliding, we'll take up the slack in the shoulder to tighten things up because the muscles can't control the stability. And then this last one is where we take a piece of bone that came from here and add it to the front of the cup to make up for bone loss in a shoulder that's dislocated many times, to make up for that bone loss. And this is for the front. In the back, we take bone either from the pelvis or from a cadaver bone bank to make up for the bone loss in the back if this is a backwards bone loss. So the shoulder can dislocate forwards or it can dislocate backwards. This is an example of a forwards dislocation, which can create a bony Bankart lesion, which is a bone breaking off the front of the cup, or a defect on the ball, which is called the Hill-Sachs lesion. Our next topic or section of shoulder injuries are fractures, and they can happen in multiple ways. In the young patient, it's usually high energy trauma, motorcycle accidents, jumping off of a snowboard ramp in the terrain park or off their bicycle. In the elderly population, it's fall from a standing height. And the proximal humerus is very commonly broken. And this is a proximal humerus fracture that's repaired with this construct of plate and screws. And given the softness of the bone and the osteoporosis in this bone, this metal balloon kind of holds the structure in shape so that things can heal better. This is another form of fracture. This shoulder dislocated, and instead of the cup breaking, there was a fracture of the ball where the rotator cuff attached. And so this hardware holds that rotator cuff and bony piece in place. And another very common fracture, usually in our mountain bikers and snowboarders, is a clavicle fracture. And you can see this clavicle fracture is shortened, has multiple pieces, and we'll fix it with a plate and multiple screws so people can get back to their lives. And this can heal in the position that it was designed to be in, with much better results, both in healing and function of the shoulder because things are back to length and in their normal positions. So that's in a nutshell kind of where the shoulder is. There's so much more that can be talked about, and I really thank you for your attention. And if there are questions, I'm more than happy to answer questions.
I have a couple here for you. First one is from Robin, and she's asking what over-the-counter anti-inflammatory medications you recommend.
So over the counter, there are a couple different forms of medication. The most common is ibuprofen or Motrin or Advil, and that works. Another is Aleve. Ibuprofen or Advil has to be taken 3 to 4 times a day. Aleve can be taken twice a day. It just depends on which one works for you. Neither of those have a significant benefit over the other. It's just each patient has their favorite. There's also something called Voltaren. It's a gel and it's a topical. And for some people who have some stomach issues, taking the orals, the topicals can be of benefit. And so for some people, that Voltaren gel that can be rubbed into your skin works a little bit better.
Okay, second question is from Linda, and she says, why does shoulder pain with limited range of motion come and go? It can be really bad, then go away for weeks or months and feel almost normal.
It depends on the problem. Most commonly, when you have a shoulder that is starting to wear, arthritis manifests with waxing and waning pain. And it can be, especially in the early stages, and you can have days or weeks where you feel nothing, and then other days and weeks when it is pretty miserable. Early rotator cuff failure can also manifest in that way, depending on how much you've used it and how much inflammation you've created by the activities you've participated in. But arthritis is most commonly the one that has that waxing and waning pattern.
So the next question is from Lydia, and she's asking how she can prevent a rotator cuff tear.
That's the hard part. You can't really prevent them. I think if you look at people over life, the rotator cuff is a part of our body that kind of is supposed to tear. And we've done studies where we've looked at people throughout the ages, and we've taken 100 asymptomatic 40-year-olds and done MRIs on those people. And we've looked at those shoulders, and if I took 140-year-olds with no symptoms and living a normal life, we'll see 1 or 2 rotator cuff tears on those MRIs. We take 160-year-olds, again, with no pain, no symptoms, and do an MRI, we'll see 10 or 15 rotator cuff tears. And then we take that same group at 80, again, no symptoms, no pain, and do an MRI of their shoulder, we'll see 40 or 50 rotator cuff tears. So the rotator cuff fails as part of life. And I would ask you to lead a normal, happy, healthy life. The best way to stay out of trouble is to stay flexible, to stay strong, and to stay in shape.
Yeah, she's answering a couple of these.
So there's a question here about the non-surgical treatment outcome of a hooked acromion. Again, today, compared to 20 years ago, or even longer, we used to think that that hooked acromion was the reason that the rotator cuff tore. We know that the rotator cuff tears because we've used the rotator cuff. A hooked acromion that is fairly large hook, it's easier to then create more problems because that failing rotator cuff can now rub easier. And so occasionally we will take that hook and smooth it off at the time of repairing the rotator cuff. But most often, treating that failing rotator cuff by trying to get the other muscles to work better for that failing tendon is the way to take care of it. And if we can't, then unfortunately that tendon may need to be repaired and that bone spur may need to be dealt with.
So I think it looks like one other question coming in from William, who says he's a side sleeper and wakes up with pain every few hours. Do you have any suggestions?
So sleep is one of the common painful times. And I think that it's probably related to gravity, partly, and that we're laying on that painful shoulder. And I've found that people have had luck by raising the head of their bed a little bit. And so by putting some bricks or underneath the legs of your bed at the head can help. Raising yourself up on pillows, or there's a wedge that some of the bedding stores will sell, have been successful. I saw a super expensive pillow on Facebook one day that you kind of lay in and it tilts you up. But that bringing you up can be very helpful. Learning to sleep on the other shoulder can be difficult, but can also be helpful.
I think that looks like just about it. If there's any other, actually one other question coming in about adhesive capsulitis. How does one know that adhesive capsulitis is developing and what to do? What do you recommend one does to stop it before it becomes debilitating?
So adhesive capsulitis is a topic that I didn't talk much about. Its common name is frozen shoulder. It's most commonly seen in perimenopausal women for no reason. Sometimes it's associated with very minimal trauma, but there's really no reason. Most often it's usually related to the hormonal issues that are happening around menopause. It can be very painful. The shoulder hurts, we don't move it. It hurts more, we move it less. And pretty soon it stops moving. And any pain hurts. The cornerstone of treatment is actually moving it. And careful use, careful movement is the best thing you can do. Because it's very hard to hurt ourselves and move it, physical therapy, massage therapy, or even using our chiropractic colleagues with something called active release technique can be of great benefit to get things moving. Occasionally, we have to do injections, and even rarer still, do we have to do surgery to get things moving.
Okay. Joseph wants to know what's some of the best stretches or exercises you can do for your shoulder.
So one of the most common motions that we start to lose as we begin to get into rotator cuff problems or difficulty is internal rotation, or that motion going behind your back. And so look it up online, you'll find something, or on our website, called the sleeper stretch. We also will have a shoulder lab on October 20th. Here, we'll put it out, it'll be on our Facebook page, but our athletic trainer and physical therapist will go over a lot of these, but it's called the sleeper stretch. And it's a way to do internal rotation stretching, and getting that motion back really helps alleviate a lot of the discomfort that you get in the early stages of stiffness and rotator cuff problems.
Okay. Nick wants to know if you can comment about the risk of long-term NSAID use and kidney damage.
So anti-inflammatory medication can be very problematic in two ways. One, or three ways. It can create trouble for your stomach because it can create ulcer issues. And so you want to be very careful that way and make sure that you've talked to your primary care doc about using that medication. If you're not hydrating, it can create kidney issues. And again, if you have a propensity to be dehydrated or not take in a fair amount of fluids, make sure that you are and that you've checked with your primary care doc. And then the last is that if you have hypertension, it can create some hypertension issues, and you want to make sure that your primary care doc is well aware of your anti-inflammatory use.
Okay. Well, I think that looks like it. If there's any additional questions, you can feel free to submit them, and we can reply to you via email if there are any other questions that haven't been answered here.